Hello, everyone. Really great to be hosting this webinar, and really excited about the panelists that we've recruited to speak and discuss increasing human milk use in the NICU. So we know that, as CPQCC, and I'm sorry, let me introduce myself, Henry Lee, neonatologist and Chief Medical Officer of the California Perinatal Quality Care Collaborative. And along with Caroline Tony Noland, we're excited to host this webinar on increasing human milk use in the NICU. CPQCC has had really a long history of working on promoting the use of human milk in patients in the NICU. Our collaborative project of breast milk and nutrition early on in our history was really a popular one that showed how quality improvement can increase the use of human milk, as well as have an impact on necrotizing enterocolitis, as well as other outcomes. Our nutrition toolkit, which is our most downloaded toolkit, has a heavy emphasis on human milk use. And over the past 2 years, maybe many of you had Caroline and I visit with you virtually at your NICU. We visited 40 NICUs across CPQCC just to really learn about the good work that you were doing, as well as potential barriers that you were facing in the NICU as you work to help families. And over the course of those visits, we heard from you that even though this was an emphasis for many of you, that there were remaining challenges. And so as part of that, we're excited to bring you this webinar. So going to the next slide, this is our agenda for today. I'm just going to first go over some of our data in CPQCC as a backdrop for the rest of the webinar. And we'll share a short video of one of our sites that has been working in this arena. Caroline will share a tip sheet that has been developed that hopefully you can access as a resource. And then the remainder of the webinar will be a panel discussion with our really great and distinguished guests. So as I mentioned, we've been working in CPQCC. Many of you have been working on the increasing the use of human milk and supporting families and our babies. And you can see this is a figure which shows the trend of human milk at discharge for our NICU patients within CPQCC. And so it's very, really great that we have seen a steady and increasing trend over the years. Next slide. But what that might mask is that it's still an area that many hospitals can improve in. This figure shows the hospitals within CPQCC, each dot and line representing a NICU. And so even though our average has increased across the state, there continue to be those NICUs that are have room for improvement. And as well, those who are maybe in the middle still have potential to try to get better, to achieve what some of our higher performing NICUs have been able to do in providing human milk for the duration of the NICU stay. Next slide. This is a similar figure as the trend chart, but broken down by very preterm. So the upper left corner shows babies less than 32 weeks for less than 1,500 grams. And in the bottom right is the figure showing the trend for those who are larger babies, greater than 1,500 grams. So both have been maybe having, that you could see slight, a gradual, steady improvement in both, but both have room for improvement. And the average for the preterm, very preterm, is around 68%. Greater than 1,500 grams is around 77%, which is a reflection perhaps of the length of stay of the very preterm infants. And so ultimately our focus, is on everybody, but maybe an increased focus on those born very preterm. The other thing that might be masked by our increased use and improvement is that there are disparities by race and ethnicity. And so although there's been a general upward trend, we know that there's a diverse population in California that we serve, as you can see here, broken down by race and ethnicity in CP2CC NICUs. And then maybe the next slide shows the disparity that exists within our NICUs. Even as we've worked on this issue, we can see that these disparities persist. Even in recent years, this figure shows that there are differences, and particularly for Black families, as well as American Indian, Alaska Native, and Native Hawaiian, other Pacific Islander groups. The average is significantly less than non-Hispanic, white, and Asian. And then Hispanic families as well, which is the largest population in our NICUs, that the rate is significantly lower in that group. And so we know we have work to do in addressing these disparities and advancing health equity. So recognizing this, we, in the midst of our visits, Carolyn and I, asked, what are you doing that's been working for you? And we also looked at the data, and we noticed that there was there's not the only one, but one of the hospitals that we noted that had a consistently high rate of human milk at discharge, and was also serving predominantly Hispanic population, and had been successful in that regard, consistently with having high human milk rates at discharge. And this was a Natividad hospital, and so we actually were able to visit in person, which was a really neat opportunity, and talk to folks there about what they were doing that they thought was leading to their success. And one thing I think I learned was that it really requires buy-in from the entire team, which you might get from this video that we'll show right now.
Increasing the rate of human milk use for NICU infants is one of the best things you can do to facilitate proper growth and nutrition. By working closely with parents and ensuring ample opportunities for skin-to-skin around the clock, you can do your part to improve this critical aspect of care. Listen and learn from Natividad Medical Center in Salinas, California, to see how this busy unit encourages human milk use.
When I come in to see a baby and the parent is there, I ask them, are you interested in breastfeeding? And I also introduce negative skin to skin and talk to them about the importance of stimulating the breast milk with the skin to skin and the recreational breastfeeding, as well as stimulating the baby's brain to begin to associate this pleasant experience with feeding.
We're a baby-friendly hospital. We encourage skin-to-skin for every baby, and that translates to encouraging moms in the NICU to hold their babies skin-to-skin. We know that preemies have less temperature instability, less O2 sat problems, less heart rate, apneas, and bradycardias when baby is skin-to-skin. The other thing I feel like we do is we're proactive. So we will go out to labor delivery and see if there are any potential premature babies that are going to be coming along.
When we are asked to go consult with a mom out there who is potentially going to deliver early, we bring that into the conversation at that time of these are the things that are going to happen to your baby in the NICU. And one of the things that you can help with is by providing breast milk to your baby. That's something you can do that nobody else can do. And so we introduce the conversation way early on, even before they deliver, when at all possible.
We have a lot of resources in the community for breast pumps, but a lot of confidence to be given to the mothers because they start pumping on that first 2 days, they're not seeing more than a few drops. They don't understand that milk removal helps get the hormones going so that the quantity of milk increases day by day.
So worried that the milk is not coming out and if the babies are hungry, they're trying to feed them the breast milk. And it's really important when the nurse calls us and we can sit there and explain to them, this is the best milk for your baby. It just takes time and they need that reassurance. Thanks to them, they have helped me so much. They helped me how to take my milk out. They showed me how to do it with a syringe, and I couldn't even believe it. It was like 1 ml, and they were saying that's a lot for the baby. She eats very little, and now I'm up to 60.
So we build team with the family, and I think that that's our success. Every day to say your baby is doing better because you are doing a great job. It's hard to do it, but it's a great job.
We are really excited because we have a couple of folks from Natividad as panelists on this call today. So Henry, thanks for sharing the data with us. I think it's important to sort of see where we are and what areas specifically we can improve in. And I think it's really helpful to see what it looks like at a peer institute. So this is the tip sheet that we were mentioning. I'll drop a link to it in the chat. But it's sort of easy to look at some of these suggestions or tips, but I think it's so helpful to see what that looks like at a place like Natividad, to see what it looks like to really incorporate those. So this tip sheet is an aggregation of the 40 interviews that Henry and I did of really creative things that people are doing. Some of our in-depth conversations with hospitals like Natividad that are really performing well with human milk use at discharge, particularly for infants of color, because we know, as Henry just showed us on the graphs, there's a lot of room for improvement for those populations, as well as some literature review. So I'm going to walk you through it. And if you do have questions about the tip sheet, about the video, about something specifically related to your NICU, to your unit, please drop those in the Q&A, and we'll have our panelists start working through those once we get to that section. So this first section, communicate with parents about the importance of providing human milk. Some of this is about basic education. A lot of people know that, oh, we should be breastfeeding or we should be using breast milk, but why? And why is that particularly useful for your infant? Those types of conversations may not be as commonplace, or parents might not be as familiar as to the reasons, the science behind why human milk may be particularly useful for that preterm population or for other NICU infants. A couple of examples in here: non-nutritive sucking, recreational breastfeeding. When an infant is ready and medically stable to do so, that can help with bonding, that can help with comfort, that can help stimulate that breast milk so that when the infant is ready to feed at the breast, they'll be ready to do that, and we'll have practiced that with the parent. Again, this idea that it is medicine, that it is a form of care that only the parents are able to really provide for the infant, that just sort of, recommunicates the importance of this. Again, another aspect would be facilitating trust with parents. Ask them about the milk that they're bringing in, how things are going, how many ounces you're using with the baby. That is, excuse me, you're able to build that relationship with them so that when the parents, may have a hard time with breastfeeding, or something comes up, or, maybe they have to go back to work or things change, they'll see you as a confidant, as someone that they feel comfortable asking questions with, that they can also be transparent with. Provide resources and materials that encourage human milk production. These are sort of physical support. This is sort of like the framework or the structure that allows parents to be at bedside more, to feed at the breast, to pump with the baby. Things like meal and transportation vouchers or cash for families, like when they're visiting, when they are at bedside, or when they are there to breastfeed. Those can be really important. We also know that lactating parents need those right things, like you need water, you need food in order to keep up your milk supply. Having loaner pumps, you can get them from WIC, but having them on site in the hospital, if your hospital isn't able to, have some loaner pumps for families. We're not saying that your hospital has to meet all needs for all families, but that there are community organizations that you do need to make yourselves aware of in your local area for how you can partner with them, like WIC, like BIH, so that you can meet the unique needs of your families. Create a culture that promotes early hand expression, pumping, and human milk feeding. So this might look like being really familiar with paid family leave. So I'm going to drop another link in the chat. We did a webinar earlier this year around paid family leave and what that can look like for NICU parents and the importance that that might have on their ability to be at the bedside. Sibling care, this is another really specific way that you can meet the needs of NICU families so that they can be at the bedside. This requires getting really imaginative. I know, especially with COVID regulations, maybe some of you have had creative programs like that you've had to put on hold. And again, just sort of reemphasizing, you don't have to, as the unit, as the hospital, meet all of the needs of families. Reach out to your community, reach out to organization, reach out to foundations associated with your hospital to sort of present this need, that it exists, because if we're not talking about it as a need, no one's ever going to fix it. No one's ever going to do anything. And then again, that just a reminder that this isn't just lactation's responsibility. This isn't just the social worker's responsibility. It's everyone's responsibility to be communicating with the family about how you're caring for the infant and how you're expecting them to show up and care for the infant as well. Encourage skin to skin as early and as often as possible. Parents shouldn't have to ask for skin to skin. So I was able to interview a couple of Spanish speaking NICU families. And one of them, in one of the conversations, the mom had said she had been there in a really low acuity ICN for 3 weeks. And she had only held her infant skin to skin once in those 3 weeks after the infant had been born. She'd only done that once, even though, according to some of the nurses and the other folks on the unit that I spoke with, her infant was medically stable and was able to be held skin to skin. But she didn't know that she could ask. She just assumed that someone would tell her when it was okay, that someone would let her know when the baby was ready to do skin to skin. So please be sure that you're communicating when the child is ready to be held skin to skin. Please make sure that you're letting parents know that and offering that opportunity every time they visit when it's appropriate, because we know the skin to skin time really promotes that milk supply. Some logistics also, when the lactating parent is doing that skin to skin, go ahead and set up the breast pump for them, because we know that expressing milk right after that is going to yield the most milk. And then the fifth point here, educate parents prenatally if possible. So you remember in the video, Natividad mentioned that a lot of times in the antepartum unit, who's going to have a child in the NICU, right? Go to them, tell them early on, this is what's going to happen. Here's how you can provide breast milk. Do you have a pump already? Can we help set that up for you? Talk to them prenatally about donor human milk, what it is, what the science is behind it, why it can be useful, particularly as a bridge until their own milk comes in or until their supply is sufficient. Get consent for that if you need to before they even show up in the NICU, just to sort of help streamline things so that the idea of breastfeeding or pumping isn't just something that they're sort of sidelined with in the midst of a really traumatic event as their child enters the NICU. So have those conversations early, have them often. And I think particularly we've noted here that families of color are less likely to have access to or consent for donor human milk use. And so I think paying attention to that is really important for that population, particularly as we think about health equity and how to make human milk use for all infants as equitable as we can. So in the chat, you'll see I've linked to this tip sheet, and I'll have a link for the video at the end as well. What I'm going to shift us to now is our panel discussion Q&A. So panelists, feel free to turn on your videos so we can see your beautiful faces. We are so excited for this group. It's such a multidisciplinary group, such a wealth of experience here. So I'm thrilled that we get to pick their brains. So we have a couple of questions that were pre-submitted. So what I'll do is I'll start with those and would really encourage you in the Q&A function on the webinar to start submitting your own questions. They can be as specific as you want. And yeah, let's see what our panelists have to say. So I would love for you panelists, I'll invite you to introduce yourself, tell us who you are, and then either perhaps tell us your best tip on increasing human milk use in the NICU, maybe something that you always do or always say with a NICU family, or maybe tell us just a short story from your experience that you think is particularly meaningful when we are thinking about how to increase human milk at discharge. So Martha, I'll start with you. You're at the top of my Zoom list. So Martha.
Okay. Thank you for the opportunity to present this. It's a topic of great value for all our patients and our NICU. I'm Martha Douglas Escobar, and I'm the NICU director at Natividad. Definitely, this is a team effort. I think that we start a long journey that commenced when we started to look at the neck rates. And in an effort to decrease it, we started to bring donor milk. And then we started to introduce it little by little, different bundle of things that help us to be successful. And the first of it was that every baby that we have a maternal consultation, we said to the family about the donor milk as a bridge for exclusive breastfeeding. So it's implanted that even before the baby's born and the consents. And then expanded that in our NICU, as soon as they enter, even the clerk is asking or printing up labels, and then the bedside nurse is asking how many bottles, how much you are pumping, given the importance that we think that it's supposed to be, correct? It's part of the nutritional efforts, and encouraging moms that have been doing great, bringing all the milk. We want to extend to have some printouts of you are doing excellent because you are bringing all the milk for your baby, correct? So it's just a recognition that is a hard work for the families and that we are here to support. I think that that's kind of what I want to see, that is not a specific one thing that you can do, is a bundle of little incrementally improving your rates just because you are adding more people that support your effort. It's a team effort. Thank you very much.
Thank you. And I'll pass it to Carolyn, who is also from Natividad.
Hi, I'm Carolyn. I'm a NICU nurse bedside, and I am so thankful for this opportunity to show what we do in our NICU, our small NICU. But we have had some really good success rates, and I do agree with Martha, it's a team effort always. And one of the great things that I think is when the parents come in, like she said, they're asked by many different people on the team how the breastfeeding experience is going, how the milk production is going. As a bedside nurse, you know, if the mom has been gone for 8 hours, I'll count how many bottles she has and encourage her to be sure she is trying to pump every 3 hours. And if I can find any hiccups as to reasons why. So we start the conversation. And if she says she just couldn't do it because she didn't have time, that's understandable. But then we talk about the scheduling and how important it is to keep up that extra work. Even though she wants to be able to sleep at night when she's away from her baby, she still has to get up every 3 hours and pump because how important the breast milk is to the babies, especially with increasing neck rates. And another little story I just wanted to share is when at discharge, the nurses have to count and log how many bottles of breast milk we give back to the mom of milk that we have stored for her that she has been bringing in. And this, just last week, I think it was, this mom pumped 100, I gave her 110 bottles of 2 ounces of breast milk to take home. And the reason why this was significant is because in our charting system, it didn't go past 100. So I had to add a whole nother intervention to say that I gave her 100 bottles back to her plus 10.
That's awesome. And what a wonderful feeling for her to know that
yeah, she has that going home. She doesn't have to stress about that. Yeah, that's a huge achievement for sure. Thank you, Carolyn. Jenny.
Good afternoon, everyone. I'm Jenny. I'm a neonatal nurse practitioner at North Bay Medical Center. We're a community level 3 NICU, kind of situated up here in lovely Northern California. We have 16 beds in our NICU, but I have transitioned over into the well newborn area full-time as a nurse practitioner for the last 7 years. So I actually talk a lot about breast milk, breastfeedings, milk production, especially with our well newborns. But I still am integrated some within the NICU. So some of the things that we've done at North Bay is provide moms with a Symphony pump right after delivery that they get to bring home. So they have access to pumps while they're visiting the hospital, but they also can get a loaner pump to bring home, and that bridges them for the first couple of weeks. We've actually had moms hold on to them for their entire infant's hospital stay in the NICU. But we give them that breast milk to bring home until we can coordinate with either WIC or their commercial insurance to secure a pump for them to use while they're at home. Donor milk is offered in both the NICU and the well newborn side. So we try to make sure there's equitable access for donor milk for any families that either their infant needs to medically have that or they choose to offer donor milk. Moms get a food tray every single day, breakfast, lunch, dinner while they're there. And similar to what Martha and Caroline have expressed, it's just a collaborative team effort with the nurses, the physicians, and families so that the families understand how integral mom's milk is to their infant and the growth and healthy outcomes for their infant.
Thanks so much. I love that it's not just like, here's a $5 gift card to the hospital cafeteria, but here's breakfast, lunch, and dinner. I think that's also just such a great job of sort of expectation around like, we really hope that you can be here for that skin to skin, for that, pumping at bedside. That's such an awesome practice, especially if we know families are traveling long distances or staying in hotels or Ronald McDonald houses or whatever. That's such a nice thing to offer. Ashley.
Hi, everyone. My name is Ashley. I am a 3-time preemie mom. I am the founder of Glow Preemies and the co-founder of the Alliance for Black NICU Families. And I am also co-chair for Within the NICU for CPQCC. I'm going to take a different approach, and I'm going to take the parent approach. But before I do that, I wanted to let the ladies know in front of me that to me as a parent, you guys sound like the fairy godmother of breastfeeding. So thank you so much for what you do. That was amazing, all 3 of you, what you said. Now, a story from me would be the 3rd time I had my preemie, the 3rd preemie. As soon as they knew I wanted to breastfeed, every time I leave and would come back and it's time for skin to skin or feeding, as soon as I walked in, the nurse would go get me my little cover. I have my chair seated by the incubator already. She do the skin to skin. And while I'm doing that, she goes and gets the breast pump. So I'm glad that you guys had brought that up earlier about having the breast pump right next to mom, because that's exactly what they did. And so as soon as the baby got put back in, she would say, "You ready to pump?" And I would sit there and I would pump, and she would encourage me and give me things to do. So she would say, go ahead and place it and then put your, a little sheet under you or your jacket or something under you to hold the pump up because they weren't hand free. And then she would say, you could use one hand to use your phone. So I would sit there and take pictures of my baby on my phone while breast pumping. And every time I got a lot of milk. So you guys all said absolutely the truth, all factual suggestions that I have used. And thank you all for being here with me today. I am so honored.
I love that, Ashley. I'm sure those pictures are so sweet now to look back on. I know a friend who was a lactation
consultant also recommended recording a video of the baby crying and listening to that while you pump as a way to sort of stimulate the milk as well. All right, Melanie.
Yes, hi, I'm Melanie, retired RN IBCLC. I'm currently working doing some consulting with Nursing Mothers Council. I started the lactation program in 1991 at Stanford, and we still have work to do. A little story I'm going to tell you is about a woman I saw in the intermediate nursery with a 36-weeker. She was struggling with her milk supply. Baby was not latching. Her husband or dad was there. And I asked her about, none of the other risk factors seemed to be of, retained fragments. She was fine in that department. She didn't have any cold sensitivity, but pumping wasn't working for her. She had short, rather small diameter nipples. I looked at her, asked to see her pump flange, and it was way too big. It had been handed to her probably sized on the diameter of her areola rather than the diameter of her nipple. And the problem with that is if your flange is too big, breast goes along with the nipple down the tunnel, and you don't get that stretch of the nipple from the breast that helps trigger letdown response. So that wasn't working. Then she had been trying to nurse with a nipple shield. I looked at the nipple shield, again, way too big. I asked her how she had been taught to apply it, and she said, oh, I just put it on like a hat. No. So what I did was I asked that we were going to work on, first of all, on getting baby attached to the breast. So I got out a different nipple shield size. It was a better size. And I asked the dad if he would stand behind me, and he was very eager. He would stand behind me and take notes that he was going to be the go home coach because baby was going to go home soon. And he was going to be deputized. He was so excited to be given a job to do and a role, and was so relieved. So I showed mom how to apply the nipple shield. You turn it partway inside out. And I had dad with a needleless syringe full of some breast milk, fill the tip of the nipple shield with milk so baby would get an immediate response and reward. I checked baby's mouth with a gloved finger, normal suck and rooting response. I had mother put her finger in baby's mouth so she could tell what baby's tongue was supposed to do. Then we had him suck about 7 times in a row to get organized, excuse me. And we worked on positioning. We did the football hold. She was holding his head. So diving into the breast. I explained the whole point is he's got to come in chin first, mouth open wide, so he can pull the nipple shield into his mouth. So we adjusted that, hold the neck, pull the baby back a bit. Dad was taking notes. He was paying very close attention. Baby latched, got an immediate reward from the full nipple shield, nursed well, paced beautifully, and was taught 10 minutes on a side, which is like, okay, you can have 5 minutes on this half of your sandwich, then you have to put it down and go to the other half. And what that does is with baby nurses on a breast and is only allowed to nurse until it starts to get soft, it trains the baby to say, oh, I have to get off now. And it doesn't get the full supply from the breast. It doesn't get the proper fat load, especially from the first breast. So, and the baby sleep said, no, when you drink, do you ever put your glass down? Yeah, baby's just pausing. That's normal. So baby was pink, pausing, was happily feeding. I called the nurse over and I wanted her to see this response. We did a follow-up weight and he took in almost 2 ounces, which was for this kid on these breasts, pretty good. And then I showed mom that put her on the pump with the new, a smaller size flange. She got a much better flow. And the next day I went in to check on them and the baby had been okay. Mom was just in tears. She was so happy. She'd been pumping more milk. Baby and it was wonderful. And I wish I'd thought to deputized, because it gave him a sense of pride, and mother really felt accomplished. It was great.
I love that, involving the whole family. Yeah, that's so needed.
Oh, yeah.
And I think does a really good job of recognizing the abilities of two parents, and what that can look like for a pumping journey. I know some families, during the middle of the night, if one is getting up to pump, the other is going to get a glass of water for the person, or even like sitting up with them, just to have some sort of companionship. I think that's a really wonderful way to involve the whole family. So I'm going to go ahead and get started with our Q&A. So the first one that we have is really specific, and I think just a great question. So the question is, other NICU hospitals are freezing breast milk for 48 hours before they can give it to preterm babies that are less than 32 weeks. Is there any evidence base that supports this practice? Do any of you do this? Martha, do you want to get us started with that one?
Yeah. No, actually, we use the fresh milk first. And I feel like that's so important because all your hormones, your cells are alive. So we use it always fresh. Now, if mom pump a lot, then we will freeze because, we will use, like Caroline said, we can have 100 plus bottles waiting for the baby. But I feel like it's very important, and I have not read anything that said that we shouldn't use fresh milk.
Great, thank you very much. How do you sustain pumping after initial success? Who'd like to take that one first?
Well, I will say that for us in Natividad is the constant reinforcement. Because when the mom is here in the NICU or in the hospital, they are a C-section, for example, or have a complicated delivery, then you're pretty much a mom that is in the NICU all the time, and it has very easy access to the baby. But when they go home, especially we have some population that live in Soledad, I mean, it's 1-2 hours from the hospital. That's when we start to apply positive reinforcement. And every time that they bring something, we find ways to get excited and cherish and said, this is awesome. This is part of the team, and this is part of the successful journey to have your baby home. And as Caroline said, we count the bottles. We have other little tools and tips, but for the most, is establishing that relationship that every time that we round, we will ask mom, how is your breastfeeding going? How many bottles are you increasing? Do you have any other problems? And if you constantly are doing that, they get the sense that that's so important that in the middle of your rounds, you're asking them about it, beside the frequent contact with the bedside nurse reinforcing that.
Yeah, I think for us at North Bay, it's probably a lot of parent and nurse and physician conversations that are had. The healthcare team members stress the importance of mom's own milk and what she's able to do for her baby. And I think they can translate that and go, I have to leave the hospital, yet I can do something very important and very valuable and, participate in the plan of care with their child. And, similar, being a smaller hospital, our physicians are able to see our parents pretty frequently. They go in and it's like having a conversation with friends, basically. It's not a medical situation. It's like we're here together to make sure your baby makes it home safely. And their growth is optimized. So I think, having that. We also have 2 dedicated lactation consultants that work in the NICU as well as in our well newborn populations. So And we're a baby-friendly institution, so all of our nurses are trained from labor and delivery NICU to mother-baby on the aspects of breast milk and breastfeeding. One thing, I don't think this really plays into this question in particular, but one thing that I learned having transitioned over into the newborn nursery is sharing with mothers the expectation, especially early on. Many moms think that once their baby is born, they just should be producing lots and lots of breast milk. And it's surprising to me the frequency of education I provide with new moms that know in the beginning you've got colostrum. And I translated into an analogy. I talk about food, and if their breakfast tray or lunch tray is there, I try to create a visual like your colostrum is that one crouton in the salad that's part of your entire lunch tray. And they go, oh, okay, I can. Or if they're doing hand expression, they can visually see how small colostrum is in the beginning. But we talk about the importance of the colostrum, and that with ongoing pumping or hand expression, especially in the beginning, that sort of sets the groundwork for making sure their milk production is steadily increasing throughout their hospital stay, especially in the NICU.
Those are great ideas. Go ahead.
Sorry. Two things that we found were helpful, and one was to talk to the mothers about the enteromammary pathway, about kissing your baby, why women want to kiss babies so badly. Nature did that on purpose, because when you kiss your baby, within a few hours, your milk is specific to your baby, which really boosts their, oh my gosh, I'm really special for this baby. I'm unique. No one can do this but me. The other one that I did was that I would have moms, I said, get a clean cloth diaper from the nurse, get a couple of them. Take one into the newborn nursery, and when you do the baby skin to skin, the part that's not on you, the back probably, put the cloth diaper on that, and then kind of cover up with a blanket and kind of rub it a little bit, and then take that with you and smell that when you're pumping, and you're going to trick your body into thinking that your baby's right there. And it just I know a lot of this is tricking, but we do smell things more than we really realize we're smelling. And anything that gives her confidence, anything that makes her feel like I'm special, I can do this. I've had a baby in the NICU. My second was premature. I was a nurse. I was a lactation consultant. They rolled me into the NICU. I was afraid to touch him. He felt so vulnerable, fragile to me. And I thought, if I don't touch him, the nurses will think I'm not a good mother. Which for someone who'd counseled babies in the NICU, just showed how fragile we can be as NICU moms. And anything that boosts our confidence, I think is worthwhile. Even do little tricks like that. Although the enteromammary pathway isn't a trick, it's real.
I love that. Yeah. Ashley.
Can I give a quick answer? So I'm going to do a quick answer from a parent perspective, because I would love to do another question. But from a parent perspective, and from what I have seen with Globe Preemies and the Alliance, especially with African Americans who has the lowest rates, they never think they are healthy enough to breastfeed. So for all of you guys, when dealing with African American families specifically, just keep reinforcing what you guys sound like you're already doing, that it's important. They are healthy enough. You don't have to worry about not eating enough fruits and vegetables. Your milk is already golden, because it's like a click, like I don't eat enough fruits and vegetables already. So how can my milk be better than a can of formula? Oh, it's a million reasons why. So let me tell you why. I think if you can get that through, then you can get the mom to breastfeed longer and the more wanting to do it. Sometimes, mom's been pregnant for 8 months, 7 months. She's in the NICU. It's a stressful time. Sometimes they want to go, they're like, I want a glass of wine. Can I even have a glass of wine? It's so stressful right now. Then once they think they can't have the glass of wine, they think they can't breastfeed anymore. So just like educating moms on what they can and can't do, and that it's not a complete shutdown is so important. And I know that the education really helped for me. And so I've been sharing it with others. So I'm hoping that that little tidbit will help with the African American rate.
Yeah, that perspective is really helpful. Thank you all. Another question we have, are there some screening questions that you might recommend asking and that might have an impact on milk supply? Go for it.
I'll be quick. Absolutely ask about cold sensitivity when not pregnant, when not on estrogen, because if they're going to be pumping and that pump is pulling at that nipple however many times a minute, that can trigger a vasospasm and you'll block the flow. So always ask about that. We have, and I'll ask dads sometimes or partners, when she's not pregnant, are her feet always cold in bed? Oh yeah. What if she pulls something out of the freezer? Oh, sure, fingers turn white. Then those are pure signals. And we have, luckily, a dermatologist who specializes in sore nipples who helps with this. But we've also got an information sheet on on pumping and medication.
That's perfect. Thank you. Someone asked, do you track and document why patients didn't get breast milk in the EMR or in some other file? If so, do you have any best practices to share? This is about tracking and document why patients didn't get breast milk, or I presume also why they did in the EMR.
I can answer that. In our progress note, like we included like the I's and O's, how much the baby's receiving. We document the mom is pumping and we document the amount more or less. And if there is anything unusual, why she's not able to provide milk, we write it there. We have, that I remember, a couple of cases of mom that did not want to breastfeed. And it was a puzzling thing. Why? It doesn't make sense. And when you approach them, we figure out pretty much that they said, I will pump, but I will not breastfeed. And that was related with a traumatic event, rape kind of things, or domestic violence. So at the end of the day, understanding from where they come and say, it's perfectly okay. You can choose that. But you're still providing milk for the baby. And we are happy with that. So we write out something along those lines. This mom will prefer to provide the milk, but not breast milk. So very specific that help the team understanding what's going on with the family. And the other thing that it surprised me, sometimes the bedside nurse said, you know, this mom is bringing less bottle or less milk. And then a couple of days after, oh, have COVID or have some disease. So it's a quick way to check on the mom. Are you sick? Do you have any other things that you need to talk to us, etc.?
I think that also just sort of really drives home the point of asking the right questions, right? Like talking to the parents and not just sort of assuming that, you know, they didn't bring in the milk, they're not interested in this anymore, and sort of moving on, but having that relationship with them where you can ask questions and it doesn't feel like shaming or guilting or blaming them for not doing enough, but just like, this is a partnership. We're both trying to do what's best for your baby, and that's so important. Another question, what do you do with people who just really aren't interested in breastfeeding at all? Maybe Carolyn, how would you approach it sort of as a nurse if someone said that? Or
Yeah,
Ashley, I know you've mentioned some parents before. Mm-hmm.
That has happened to us before. And we just try to educate the best that we can, but we also respect their decision. We ask them, what is it that's uncomfortable about it? Whether they only want to pump and they don't actually physically want to have the baby at their breast. Maybe they're just also very private. So we do actually have a separate room as well for the moms to pump in if they're not comfortable pumping at the bedside, even though we do provide a curtain and, you know, covering and all that stuff. But some parents, some moms just don't feel comfortable unless they're in a private room, and that's understandable. And some mothers also do not want our help with latch, and that's okay too. We just, like you said, we always try to have a conversation. We also try to keep our assignments the same. You know, a nurse is working 3 shifts in a row. She tries to have that relationship with the mom so that they can feel comfortable with each other about talking about breastfeeding. We also have, you know, I think a significant population of young moms, and these moms can tend to be very shy. You know, they don't want to have another mother telling them what to do and how to do it. So sometimes they just want to do their own thing. But we give them pamphlets, we talk to them, we have lactation talk to them. But once they have made that decision that they don't want to, if it's a solid decision they don't want to, we try to make it clear to everyone on the team so that we are not hounding or stressing out the moms more. And Dr. Douglas will say that, you know, especially if it's a small preemie, we always offer donor milk, and hopefully those moms will sign the donor milk consent, and we will continue to give these babies donor milk until we feel it's safe that they can transition to formula.
And I want to share one more thing. I think that Caroline is talking about. We have a series of teenager moms, 15, 16. So what is the normal, regular for a teenager? As soon as the mom comes and said something, they will say no. So we have some that at the end, after listening to us so many times and talking about the human milk, they finally start. And one point of understanding is I come to say, you know, if you cannot provide all the milk, that's okay too. But a little bit is better than nothing. And then they start the commitment to saying, okay, I can provide, but it's not 24 hours. It's not exclusive job. No, a little bit. And then slowly by slowly, they get more engaged, and you can put it to the breast. It's recreational breastfeeding. It's not that you need to produce anything, just put it in there. And as soon as they start feeling more comfortable, I feel like we have some result. But I need to disclose, there are some others that have the setup, I will not breastfeed, or I will not do having this experience, and it's very difficult to move, and we respect that too.
We have about 1 or 2 more minutes left. We've also answered a lot of questions in the Q&A chat. We've typed the answers out, so if you want to take a look there, please do. Does anyone else have any last closing comments they want to say, or something they feel is important to mention?
I've just learned so much from everyone. Thank you.
Great. Well, let
Jump
me
in and just say thank you, everyone, for all that you do.
So as a wrap up, I just want to make sure I send out the links. So here is the link to the video that we showed you from Natividad, that sort of gives you an inside look at a NICU that's doing this really well. And here is a link to the tip sheet. You can also scan those QR codes right there. I also put a link in the chat to a webinar on marijuana and breastfeeding. So if you think someone is using marijuana, what does that mean in terms of their ability to pump or to provide milk for their child? Martha's also, I'll share this in the chat as well, but linked a paper. Yeah, perfect. Martha, I might have to send it out to everyone, but I'll be sure to do that in the follow-up. But this, guys, it's been a really wonderful conversation with you all. You are all doing really great work. I think Martha says that at the end of the video, and I just want to drive that home, that you are all doing really great and important work, and it is hard work. So thank you very much for being willing to partner with families in this, recognizing that it's not just something that you can sort of do as a healthcare professional, but that it is a conversation and a dialogue with families. So thank you all very much. Thank you for coming, and enjoy your weekend.
Thank you.
Thank
Thank
you.
you.
Thank you, everyone. Have a good day.